To you, Vivek.
Thank you, sir. Thank you for the kind introduction. So, good evening, all. Now we are moving to the next session topic of VA. What exactly it is? So, if we talk about the ECMO circuit, it is same. You are draining blood through your venous cannula. It is coming to a centrifugal pump, and it is being pushed to your oxygenator. And after getting oxygenated and gas exchange, carbon dioxide removal, it is now the oxygenated blood is being pushed to the artery, and when it is being pushed to the artery, it means this is the VA ECMO configuration, because previous speakers have talked about the VV ECMO. So VV ECMO means you are returning back to vein itself, so you are not touching the arterial system, but here you are pushing the blood back to a major artery. The most commonly in ICU is the femoral artery, but other arterial access like an axillary artery, or in cases of pediatric patients, we can have an access of carotid artery as well for initiating a VA. So the most important question comes, how you identify these patients who will be a candidate, because this is very, very important that we understand that which patient is going to be a candidate for VA. So there must be some issues with the heart, because when we say VA, it means it is going to support heart as well as to the lung as well. So when there is a severe myocardial dysfunction, and which is leading to a ejection fraction less than 25 or 20%, and cardiac output is low, you get a signs of hypoperfusion like a cold clammy skin. Patient in the initial phases of shock is irritable. In the late phases, he becomes drowsier. You may get a signs of pulmonary edema. Patient is having some metabolic changes in the form of severe metabolic acidosis, and lactates are rising, and there is a drop in the urine output. Patient is having a persistent hypotension in spite of high inotropic support, and receptive inotropic score is rising. And as per the ELSO recommendation, you should consider these patients for VA ECMO when the inotropic score goes beyond 20. But to be honest, we come across with the patients whose inotropic score is above 100 when actually we try to initiate ECMO in these patients. Or there is another category of the patient who are having a refractory arrhythmia in spite of all possible medical management of antiarrhythmics, other maneuvers, patient is still having arrhythmia. So in those conditions, you can, these are the candidates for VA. So this is the uh, criteria when you should start thinking that this patient will definitely going to require VA. Whenever we talk about ECMO initiation, quickly we should look for a destination. What exactly we want to achieve? Whether ECMO, because we know that the ECMO is a bridge, it is not a definitive therapy. So whether it is going to be a bridge to recovery, which we accept more in most of the cases, like a toxic myocarditis, viral myocarditis, or acute coronary events, there we expect that these patients may recover. Or the heart has become so bad, or it's a chronic issue, that this can become a candidate for transplant. Or sometime in the toxic patients, when there is a cardiovascular collapse, probably doing a dialysis and removing toxin till the time we are removing toxins by renal support, possibly they can be a candidate for VECMO. And it can be for a long-term bridge, like a LVADs or RVADs or BiVADs. And definitely any patient you are putting on ECMO, it can be a bridge to decision, because so many times you are not clear about the diagnosis. So you can decide whether to continue with the ECMO with the destination therapy, or we have to withdraw the ECMO support in these conditions. So whenever you are thinking of initiating ECMO, this is the time to think about outcome, because this should be a definite part of the counseling of the patient relative. The physiology has been described by Dr. Pranay nicely. So we can just say that when we talk about the VECMO, we are not going to give 100% support. Our target is just to achieve 60 or at a max 80% of the resting cardiac output. And for which, in an adult patients, we generally look for a target of 62 ml per kilogram per minute of the flow. But we should always remember that ECMO flow rate will be depending on the preload and afterload, because it is affected when there is a low preload is low or afterload is high. So in those conditions, your flow may drop down on the same RPM which you have set. So that, because we are using the centrifugal pump. Who all are important when we talk about that? So it's a dedicated perfusionist, because during VA ECMO there are a lot of challenges. So you should have a dedicated perfusionist when we talk about the VA ECMO. Nursing staff, doctors, because you need a cardiac surgeon if you want to have an access with the open techniques or semi-surgical technique, anesthesiologist, ICU specialist, and other specialty as and when required. And what is most important, that a vigilant monitoring of the patient, because you are accessing a major artery. So you have to be very, very careful, because it can affect the hemodynamics drastically if not managed very well. So what are the different clinical conditions when we have an issue when we do that? So failure to come off the intraoperatively for a cardiac surgical patient when we are failed to come off cardiopulmonary bypass. These are the candidate for supporting heart for next 24 to 48 hours, 72 hours, or any condition which is producing a low cardiac output state, which is leading to a multi-organ dysfunction. And we should remember that we should not allow patient to reach to a level of multi-organ failure, but this should be initiated early. Cardiogenic shock, it can be of ischemic origin, acute or chronic, or non-ischemic like a septic or fulminant myocarditis of various origin of viral myocarditis, postpartum myocarditis, or toxic myocarditis. Or another important area where a VA ECMO is beneficial is the cardiac arrest. When you have a cardiac arrest and it's a refractory cardiac arrest where, in spite of high quality CPR, you are not able to revive your patient in those conditions, and you are aware that this is the condition which is treatable in those conditions, emergently with ongoing CPR, you place VA ECMO in these patients, and what we call it as ECMO CPR, when you initiate an ECMO and you proceed for definitive treatment, because you are supporting the perfusion, organ perfusion, and cardiac output. So you don't need to do CPR once you have initiated that. So the common indication if we look for is refractory cardiogenic shock of any origin like acute coronary syndrome, myocarditis, peripartum cardiomyopathy, decompensated cardiomyopathy, or primary graft failure after the cardiac transplant. Can be a post-cardiotomy shock, or there is a refractory life-threatening arrhythmia, ECPR situation, whether it's a cardiac arrest and which is refractory to the conventional management of CPR, massive pulmonary embolism. For this, I would like to say both VA and VV ECMO will be beneficial depending upon the clinical situation. If a patient with the pulmonary embolism is hypoxemic and not responding to the conventional oxygen management, then he's a candidate, he or she is a candidate for VV ECMO. But suppose this patient is having a massive pulmonary embolism, is having a cardiac arrest. In those conditions, VA ECMO will be beneficial. Accidental hypothermia, drug overdoses, poisoning, a drug like calcium channel blocker, beta blockers, periprocedural circulatory support, septic shock, especially VA ECMO will be beneficial when there is a septic myocarditis, embolism of any origin, anaphylactic shock, or any traumatic injury to the heart and great vessels where we need to support the cardiac output. And it helped to facilitate the transferring the critically ill patients who are at a risk of cardiovascular collapse during the transplantation. So what we want to achieve by placing the patient on the ECMO, we want to give rest to the heart so that we do not run behind the numbers of blood pressure, so that it allows us to reduce the use of inotropic support, which on one end try to increase the blood pressure, but on the other side, at the cost of failing myocardium. We can give rest to the lung by keeping the rest ventilator setting, and it helps to improve the end organ and tissue perfusion if we maintain a cardiac index around 2.2 to 2.5. And it helps to improving the oxygen saturation and help for carbon dioxide removal. And definitely it allows time for the medical or interventions, and we can control the temperature as well. But whenever we look for an indication of doing a ECMO, at any ECMO, whether it's a VA or VV, we have to look for absolute contraindication. And for VA, if a patient is having a aortic dissection or severe aortic regurgitation, this is a absolute contraindication for placing these patients on VA. End stage cardiac dysfunction, where we do not want any destination like a VAD or transplant, then these are not the candidate. Or any end stage pulmonary dysfunction who is not a transplant candidate, our patient is having some irreversible severe neurological injury like a ICH or some other issue, who are the these are the absolute contraindication for doing VA. Relative contraindication includes advanced stage. Usually, you have to look for decide on the case to case basis. Hepatic failure, advanced malignancy, active bleeding, and contraindication to anticoagulation, especially when the patient is having ICS. So these patients should be actually on the individual case-to-case basis to decide about doing or not doing that. So these are the certain situation when there is an unrecoverable cardiac functions, or there is a chronic organ failure, or there is a prolonged CPR more than especially in cases of unwitnessed cardiac arrest. These are not the candidate. There are some compliance limitations like financial issues or some psychiatric issues or social limitations. There we should not consider these patients for doing an VA. So we have to think of patient's age, prognosis, comorbidity, and our weaning strategy before initiating the ECMO. And for that, we can use a SAVE score as a good tool to look for a survival prediction, which includes several parameters, including the primary cause for the putting the patient on ECMO, including age and other issues. You can fill it and you can see the chances of survival in the patient. So how do we initiate the VA? We can do in ICU most of these patients. When we talk about the ICU ECMO, this is the peripheral cannulation, and the most common combination is the femoral vein and femoral artery. Femoral vein as an access and femoral artery as a return. Besides this, we can use femoral vein and axillary artery, internal jugular vein and carotid artery in the pediatric population, or internal jugular vein and axillary artery. The benefit of using axillary artery is the differential hypoxia, which Dr. Pranay was talking, can be avoided and patient can be mobilized. Central cannulation has its own benefit as well as its complication. Usually restricted for those patients who are a post-cardiac surgical patient where we have a difficulty of coming off bypass. The benefit is we can achieve a very high flow, which may be required in, especially in cases of dengue myocarditis or septic myocarditis, where higher flow is required, which is not achievable with the peripheral cannulation. However, there is a more risk of bleeding, risk of mediastinitis and other infection because we are doing it with the sternotomy. So we'll be discussing these details of the cannula during the cannulation section, but we should remember that these cannula, when we made up of polyurethane and peripheral cannulas are larger, and we should put as big cannula as possible to ensure a good uh, flow, good blood flow at a lower pressure. So usually for an adult patient, the drainage cannula is around 25 French, and return cannula means arterial cannula will be 17 to 19 French. And when we talk about the VA ECMO, it means we should ensure that we are ensuring a distal perfusion. Distal perfusion means when we are replacing 17 or 19 French cannula in the artery, the distal limb perfusion may compromise, and we should ensure that we are putting a 7 French sheath which is connected to the arterial cannula so that a distal limb perfusion can be maintained to prevent any ischemia or gangrenous changes in the lower limb. So, how we do the peripheral cannulation? Peripheral cannulation can be done percutaneously, or what we commonly call the Seldiger's technique, or it can be a modified Seldiger's technique, and it can be done as a open or surgical cut down technique. I'll not go in detail, but the percutaneous technique is usually in VA ECMO. You can do it very emergently. The advantage is that minimal risk of bleeding, and because this can make a tight seal, and you can use a distal perfusion also percutaneously under ultrasound guidance so that you can ensure the adequate perfusion of the distal limb. But whenever you are closing it, it should be done surgically because artery gets shears and there is a more risk of post procedural complication if we don't do it surgical repair. So this is what the Seldinger technique. We all know. I'll not go in detail. These are the percutaneous cannulas. You can see these red caps are the shorter one is the arterial cannula, and these longer one and thicker one are the venous cannula. And we have the complete kit, including the dilators, serial dilators, so that we can do the cannulation percutaneous. Central cannulation means you are going to place directly your cannula in the return cannula in the aorta and access cannula in the right atrium, or we can do a two-stage like SVC and IVC separately after doing the sternotomy. That we should remember here, the sternum has to be open. So the different arterial location can be a femoral. The advantage is we can do a rapid cannulation, but there is always a risk of upper body hypoxemia or differential hypoxemia. And because the blood is flowing in the opposite direction, so it may affect the aortic valve opening and it can lead to LV distension. And because the distal limb perfusion may be compromised, so there is a risk of limb ischemia. And whenever we are doing a femoral artery cannulation, we should remember that blood gas monitoring should be from the right radial artery. And if it is not possible, then at least we should continuously monitor the oxygen saturation in the right fingers. The another access return cannula can be placed in the right axillary artery, so it helps in the mobilization and lower risk of upper body hypoxemia. But there can be swelling, and that may require a surgical anastomosis. And here we monitor the left radial artery. Similarly, in the left axillary artery, the similar issues we should monitor the right radial artery. And if we are doing a central cannulation, the advantage is we can achieve a very high flow, no risk of upper body hypoxemia, but there is a more risk of bleeding, risk of infection, sternotomy related issues, and we can monitor any of these arteries. There is no issue about it. In the pediatric population, we use the common carotid arteries, which facilitate mobilization, but there is always a risk of stroke in these patients. So what is the algorithm for selecting a patient? You should look for an indication. Yes, the indication is there. So we ensure that the conventional therapy has been optimized. If the answer is yes, we look for a contraindication to VA ECMO. If there is a no contraindication, we see that what is the possible destination, whether it's a recoverable patient. If yes, then VA ECMO is used as a bridge to recovery. But if it is not a recoverable condition, then we have to look for a destination. What is bridge to destination? Whether it's a transplant or it's a bridge to bridge or a bridge to any definitive therapy. So accordingly, we plan for placing the ECMO after discussing with the patient. Monitoring, the standard monitoring we do in ICU, all we do as a ECG, heart rate, invasive blood pressure. But what is important here is we look for the pulse pressure. It should be not less than 10. It should always be above 10. If it is less than 10, it is suggestive of myocardial stunning. And in right radial artery should be monitored, blood pressure as well as oxygen saturation, so that if it's a femoral cannulation, it means we avoid any risk of upper body hypoxia. Besides this, monitoring urine output can be a very good guide by looking at the color as well as the quantity. Gas exchange, we monitor by looking at SpO2. However, central venous oxygen saturation, Dr. Pranay has already discussed that this will help us to identify that adequate tissue perfusion, adequate oxygenation is taking place. We look for cerebral saturation, and definitely capnography can guide us that for improve any trend will guide us for improving the cardiac output. You should remember that peripheral femoral artery means your pump flow is a retrograde, and there is a admixing of the blood at different level of arch depending upon how much blood is being ejected from the heart. As that is going to decide the risk of differential hypoxemia if the lung is not working well. Because if the blood which is being ejected from the heart, it is going to the right common carotid, and coronary circulation, that is going to, if it is not well oxygenated, it will lead to upper body hypoxemia. Monitoring ECMO parameters, we should monitor the accuracy by looking at checking the circuit hourly, checking the machine for the blood flow rate, sweep gas flow rate, and how much revolution. And we look for oxygenator for the delta pressure and post-membrane blood gases to ensure that oxygenator is functioning well. And efficacy, we assess the clinical and biochemical parameter, and goal is to ensure that adequate tissue perfusion with the minimal complication. And we look at the ECMO efficacy by looking at mean arterial pressure, mixed oxygen saturation, and decreasing trend of the lactate levels. We measure several pressures like a pre-pump pressure, post-pump, pre-oxidative pressure, and post-oxidative pressure, and we look at delta pressure. We assess the ensure the safety by looking at the adequate anticoagulation by checking ACT. Initially hourly, then gradually we increase the time was the ACT is stable, keeping a ACT around 180, and we look at the hemoglobin. And for any hemolysis, we look at the plasma-free hemoglobin and for the hemoglobin urea. We keep the patients on the rest setting. We'll be discussing in detail how we have the ventilatory strategy. Our purpose is to keep the low plateau pressure. We gradually reduce and we keep FiO2 low. And we ensure adequate anticoagulation by giving the heparin as a loading dose while cannulating. And the anticoagulation is maintained with the heparin infusion by keeping heparin infusion and maintaining an ACT around 160 to 180. Hemodynamic targets for an adult, I try to keep mean arterial pressure around 65 to 80, and we ensure that there is adequate preload which will maintain adequate flow with a similar RPM, and we keep reducing the vasopressors. Once we achieve these targets, we reduce the vasopressors because most of these drugs at a high doses increases the afterload. Sometimes to enhance the cardiac contractility, we require an inodilator in the form of dobutamine or milrinone, or sometimes you need to put an IVP in these patients. A regular monitoring of echocardiography is crucial during the VA ECMO management. If there is a hypotension during VA ECMO, you have to look for a cause. Most of the time, it is a bleeding or drop in hemoglobin or inadequate preload, and when there is a loss of pulsatility or cardiac contractility. So ensure an adequate preload, correct hemoglobin if the hemoglobin is less than 10, and sometimes we need to add vasopressors if there is a vasodilatory shock because of the systemic inflammatory response. Myocardial stent, one of the most um, issues when we put a patient on VA ECMO, when the heart is not ejecting and aortic valve is not opening. So we have to be careful. We have to make sure that there is a pulse pressure is above 10. If it is not so, we may need to support. Now, common causes are the severe LV dysfunction, are high bronchial artery return to LA, are incomplete venous return, aortic valve insufficiency, or electrolyte imbalance. What happens in this situation? That there is a LV distension, and there is always a risk of LV thrombus. The treatment can be a non-surgical one by ensuring adequate preload, using inotropes, or decreasing ECMO flow, or correcting the electrolyte imbalance. And sometimes we need to provide it mechanically by putting an IABP, or doing LV decompression by using surgical techniques with from the apical venting or some other ventings from the other places. Fluid overload is quite common, so we have, because initially we give a lot of fluid during the initial phases, and it is associated with a high mortality. So we have to ensure that once the patient is stabilized, we are keeping a patient dry, or we are making a negative balances. Make sure that electrolyte imbalance is not there, which can precipitate any kind of arrhythmia, and keep assessing your echocardiography and stroke volume variation to ensure the adequate fluid status. The common complication we come across, it is anywhere hemorrhage, starting from intracranial hemorrhage, pulmonary hemorrhage, gastrointestinal hemorrhage, hematuria, limb ischemia, sepsis, cardiac tamponade. All of these complications are possible, and one has to be very, very careful in this situation. Another complication we see, the loss of pulsatility. That means there is a risk of LV or aortic thrombus, and there will be LV distension, which will increase the myocardial oxygen requirement, and there is a risk of pulmonary edema, hemorrhage. So we have to support with the inotropes or decrease ECMO flow and put a IABP. Upper body hypoxemia already has been discussed, a differential hypoxemia that can lead to a cerebral ischemia, pulmonary ischemia. So that we need to ensure that adequate oxygenation is taking place through the lung. Limb ischemia, which can lead to even the amputation sometime. So we should ensure a distal perfusion cannula either in the femoral artery, or we can put the posterior tibial artery as well. Risk of bleeding, which leads to hypotension, need of blood transfusion, and there is inadequate oxygen delivery and reduction in the ECMO flow. So we have to make sure that there is a control of the bleeding wherever it is happening. Other issues, low flow, which can be related with increased afterload or low preload, low mean arterial pressure. You have to assess that there's a bleeding or there is a surge which is leading to a decrease in the volume status. If the PO2 is low, we have to increase the FiO2. Make sure that your oxygenator is working well, or you may need to increase the ventilatory setting. If there is an increased PCO2, we have to increase the sweep gas flow, or we have to increase our ventilatory settings, ventilator rate, and tidal volume. Low SCV2 means you have to increase the ECMO flow. We have to ensure that adequate PaO2 is adequate, and if needed, you may transfuse the blood. If there is a rising level of lactate, that means your ECMO flow is not adequate to match with the patient's need. You need to increase the ECMO flow, or you have to look for some ischemia somewhere. It can be a limb ischemia, distal problem with the distal perfusion, or there can be gut ischemia as well because of embolization. So you have to be very careful if there is a rising lactate level. Bleeding, the causes of bleeding may be because of anticoagulation. There is a risk of TIC, or acquired vulnerable brand disease, infection, thrombocytopenia, and platelet dysfunction are quite. It can be surgical site bleeding. The incidence is very high, maybe 30 up to 30%. Cannulation site, GI airway bleeding, or catheter insertion bleeding. So, strategy for reducing bleeding, we can use the heparinized circuit. We can keep ACT on the lower side, but you should remember that your flow should be adequate. Low dose heparin protocol, use of topical agents to reduce the bleeding. And whenever there is a bleeding from the surgical site or cannulation site, you should ensure that adequate hemostasis has been done. So if you look at the complication, the bleeding complication, look at the coagulation pattern, do a viscoelastic test in the form of TEG or ROTEM, and monitor the circuit for any coagulation activation. And choose your single factor and cells depending upon what is the problem. So fibrinogen, packed cell, platelets, or plasma, whatever is required, and sometimes you need to change the circuit if there are clots in the circuit. Neurological problems, you do the standard monitoring, and if there is a brain injury, you look for the biomarkers and optimize coagulation. Make sure that if there is any intervention related to the neurological interventions, or you require a rehabilitation. Vascular complications, limb perfusion, you do a Doppler, and in case of ischemia, you put a reverse cannula through the posterior tibial artery, and if there is a thrombus, you do an embolectomy and do a vascular repair. If there is an infection that will lead to a alteration in the gas exchange, you should send a routine cultures, active surveillance should be done, and if there is a hemodynamic instability or there is a issues with the lung, you need to increase the ventilatory parameters. You have to make sure that you are optimizing the hemodynamics and you are using appropriate antibiotics depending upon the cultures are as per your hospital protocol. So to conclude, veno-arterial ECMO can be used as a bridge to recovery or for the definitive therapy for several conditions, including cardiogenic shock, pulmonary embolism, intoxication, poisoning, or hypothermia. Important consideration when developing a cannulation strategy for veno-arterial include cardiac and pulmonary function and need to be mobilization, anticipated duration of support, and the urgency of time to cannulate. Everything has to be taken in consideration because if there is an urgency and we are in CPR situation, we can go for percutaneous cannulation, but if we have a time, probably open technique may be a better one. Careful management of these patients who are on the VECMO is required to minimize the risk of common complications such as limb ischemia, bleeding, infection, thrombosis, and cerebral ischemia. And we have to make sure that there is adequate rejection by looking at the pulse pressure more than 10 so that we minimize the risk of LV distension and subsequently formation of thrombus. Thank you very much. I'll be happy